Hello, future nurses. This is Professor Flourish. Today we're going to talk about neurological emergencies, part 2, focusing on strokes. So, like always, we'll begin with the anatomy and physiology. And this is just a refresher of what we talked about a while back with this decussation, which basically means that the neurons in the brain run downward and cross at the medulla to the opposite side of the spinal cord. So what this is basically saying is that the hemisphere that controls the counterlateral side of the body. So for example, if you've got a lesion on the right side of your body, you're going to have dysfunction on the left side of your body and vice versa. So just kind of keeping that in mind when we look at these different types of stroke. So the first disorder I want to talk about is transient ischemic attack, or your TIAs. So a TIA is a disruption of cerebral circulation with neurological deficits that are reversible and last for fewer than 24 hours. So these are basically just things that kind of have that temporary episode of neurological dysfunction, but they go back to being normal again. Like I said, it's a temporary episode of neurological dysfunction, and TIAs lasting longer than 24 hours without interruption are termed reversible ischemic neurological deficits. Many people call them mini strokes, but that's not an accurate term for them. They do not leave permanent neurological injury like a stroke does. So we're going to be talking about strokes, both hemorrhagic and ischemic. So just for some general information, a cerebrovascular accident is a stroke, a brain attack. So you'll see these different terms used for this type of disorder. It involves a disruption in the cerebral blood flow, secondary to ischemia, hemorrhage, brain attack, or embolism. So like I said before, we've got a hemorrhagic and ischemic stroke. A hemorrhagic stroke usually results from a rupture and hemorrhage of the cerebral artery, so compression of brain cells and loss of cerebral blood flow. And remember, blood is toxic to the brain cells. Ischemic is a thrombus or an embolus, which lodges in the cerebral artery and blocks blood flow to the brain. So it's ischemia of that brain tissue, and that will cause a cerebral infarction or the death of brain cells. So you can have a thrombolytic or an embolytic for your ischemic strokes, and they can be reversed with fibrolytic therapy using your TPA if given within 3 to 4.5 hours of initial manifestations. I like this picture here because it kind of shows the difference between the two major types of stroke. On here, you've got ischemia or ischemic stroke, which you've got your major predisposing factors such as AFib, carotid stenosis, which is one of the main ones, and cerebral arteriosclerosis. So on here, what you can see is right next to the, yes, you can see where they're showing this narrowing through here. A hemorrhagic stroke is, like we said before, it can be something like you had a cerebral aneurysm and it bursted, and now the blood is pouring out into the tissue area. If you remember from our last lecture, with intracranial pressure, you've got that ratio of 80% brain tissue, 10% CSF fluid, 10% blood. So with this one, we're adding a lot of blood, which is toxic to the brain. Some of your major predisposing factors are things like hypertension, oral anticoagulants, and cerebral aneurysms. So we're going to talk about our hemorrhagic stroke first. This occurs secondary to a ruptured artery or aneurysm. That's usually what will cause it. Prognosis is typically poor due to the amount of ischemia and increased intracranial pressure caused by expanding collection of blood. So, like I said before, we always kind of want to watch our intracranial pressure. And in this case, we've got a lot more blood that's causing it to be more pressure. Now, if it is caught early and you're able to take the clot out, with stopping of active bleeding, prognosis improves significantly. So our goal, that's why with these brain attacks, we try to hurry and get the patient to imaging as fast as we can. And remember that blood is toxic to the brain. So going into our ischemic strokes, the first one we have is our thrombolytic. This occurs secondary to the development of blood clots on an arteriosclerotic plaque in the cerebral artery that gradually shuts off artery and causes ischemia distal to the occlusion. So manifestations evolve over a period of several hours to days. So on this thrombus one, you can see where they've got the thrombus that's blocking off blood to the brain. Embolytic are caused by an embolus traveling from another part of the body to the cerebral artery. Blood to the brain distal to the occlusion is immediately shut off, causing neurological deficits or a loss of consciousness to instantly occur. So here we've got that fatty plaque or blood clot, which is that embolus, and it breaks away and flows to the brain where it blocks an artery. So the difference is kind of where an embolus is something that's traveling, while that thrombus is something that's staying in place. Either way, both of these can cause that ischemic stroke. So now we're going to get into some of the etiologies of stroke. What causes these things? So what are our cause? What is our risk factors? So with our etiology, with ischemic stroke for embolytic and thrombolytic, you've got cerebral arteriosclerosis, which causes that cerebral insufficiency. Carotid stenosis and arteriosclerosis, or that carotid plaque, is one of the main ones. And it's important to kind of know what your etiology of the stroke is, because if we know that our patient has these carotids that are filled with plaque, then we can go ahead and get them on the way of clearing those out to prevent a future stroke. AFib is also an etiology of ischemic stroke, because if you remember with AFib, our heart is not pumping the way it should. We basically have it quivering, where one side is going at a different rate than the other side of your atriums versus your ventricles. And with it, and the blood basically likes to get together, and then it ends up causing that clot. A hemorrhagic stroke, some etiologies for those are things like hypertension, because think about it, if I've got a lot of blood flowing, then it's going to cause that increased pressure, and aneurysm rupture. And the circle of Willis is a frequent site of that aneurysm formation. So as you can see here, we've got the aneurysm. So instead of blood going through the vessel, it kind of goes up here, and it goes and goes and goes until it finally pops. And then we've got blood becoming toxic to our brain through there. So we're going to go kind of a little bit more into detail about some of these. So the first one is arterial fibrillation, so AFib and the ischemic stroke. In the left-sided AFib, the left atrium is quivering, not contracting sufficiently, and this leads to a stasis of blood in the chamber, which increases susceptibility of clot formation in the left atrium. Once formed, clots can travel from the left atrium to the left ventricle into the aorta. From the aorta, the clot can ascend into the common carotid artery to the internal carotid artery and lodge in the middle cerebral artery, which leads to brain tissue ischemia, which leads to cerebral infarction. So that's basically how the AFib works, is it's shaking and it causes the blood to clot, and it's going up through here because there's your thrombus, and now it's turned into an embolus, and that embolus is collecting up all the way until we get into that middle cerebral artery, and it blocks, causing the stroke. How does carotid stenosis lead to a stroke? So carotid stenosis is this term used to indicate a narrow carotid artery. When plaque narrows the carotid artery, it can cause a stroke in two ways. The most common way is that part of the plaque breaks off and forms an embolus and travels through the blood vessels until it lodges into a tight space and basically blocks off blood flow to that part of the brain. The tissue then dies due to lack of oxygen, and all of this is called that ischemia. The other type is basically if this becomes narrowed, we're not getting enough blood flow up through here, and it's causing them to not have enough blood flow, which kills that tissue. So pathophysiology of the stroke. So those were our etiologies. This is our pathophysiology. This is what's happening with the stroke itself. We're going to focus on some of our ischemic issues. So for our ischemic penumbra, The penumbra is the parameter around the core. So the parameter around the core is the ischemic area. So here we've got an ischemic stroke. So as you can see, the stroke happened on this area that branches off the middle cerebral artery. And you've got the core of the ischemic region, the ischemic penumbrum, which is around it, and then the actual ischemic stroke. So what you need is that rapid reperfusion. Is critical because if left untreated, the penumbrum will also succumb to ischemia and infarction. The core of the ischemic region is irreversible cerebral infarction in minutes. Brain cells that lie at the perimeter of the core region are hypoperfused but are not irreversibly damaged. So what all this means is basically we have the stroke here. This core here can no longer be salvaged. So this core here is basically dead tissue. So that area there is the core of the ischemic region. So I can't reperfuse it. However, this ischemic penumbrum, and this is why we want to hurry and get perfusion as fast as we can actually save this area here because we can get perfusion back and we won't necessarily lose this. However, the longer we go without saving this area, the more likely it is that we will lose this tissue here. So cerebral edema occurs within the ischemic penumbrum and surrounding brain tissue. This contributes to hyperperfusion and further damage of brain cells. The swelling brain cells are enclosed by the cardinal bone with little room for expansion. So compression and cuts off blood supply. That lack of circulation equals lack of oxygen delivery to brain tissues. Pressure that builds up within the skull is directed downwards to the foramen magnum, the area where the spinal cord enters the brainstem. If cerebral edema causes pressure on the brainstem, the level of consciousness, vital signs are all affected, and there is a potential for death. So basically, what happens here is you've got this little area here, which is the core, like I talked about. So all of that is basically dead tissue. Then you've got the ischemic penumbrum that's around it, and that's all hypoperfused. When that happens, you have that cerebral edema that happens afterwards, which only makes the hypoperfusion worse. Oops. So pressure on the brainstem. So what will happen is with all of this swelling, because the body's kind of trying to make up for this damage here. Because remember, whenever we have any sort of tissue damage, our body wants it to become inflamed so we can try to send nutrients there. And we'll talk about this more when we get into our immune system lecture. So now we've got this brain that's swelling. So what happens with all the swelling brain is it's putting pressure on the brainstem. We talked about this briefly in our last lecture, but that's what we get concerned about. Our Cushing's triad is like that late sign of increased intracranial pressure. So that's things like our brachopnea or irregular respirations, our bradycardia, and our hypertension. So with our hemorrhagic stroke pathophysiology, you have the rupture of a cerebral artery, blood flows into the brain tissue becomes compressed and often displaced, which leads to tissue ischemia and cerebral edema. Brain cells downstream from the rupture are not supplied blood and oxygen, which causes tissue ischemia. Vasospasms of adjacent blood vessels occurs from exposure to blood, which subjects adjacent tissues to ischemia. Blood is chemically toxic to brain cells, and after a few days, the arterial bleeding ceases and the blood clot forms in the area of the bleed. So like I said, the first thing that happens is they've got this rupture of the cerebral artery. That blood flows into the brain tissue, and the tissue becomes compressed and displaced, which can lead to that ischemia and cerebral edema. All of this kind of causes that swelling, and the thing we're worried about is not getting enough perfusion to our brain. The other thing that can happen is the vasospasm of adjacent blood vessels. So vasospasm is basically like this quivering of blood vessels, and that is going to make it more difficult for us to get enough perfusion to our brain. So a lot of our care for hemorrhagic strokes are kind of geared toward preventing these vasospasms. Okay, so our preventions and risk factors. So for our preventions, it would be things like early treatment of hypertension, watching our blood glucose, not smoking, and regular exercises. All these things can help you prevent yourself from getting a stroke. Some of the risk factors are things like cerebral aneurysm, an AV malformation, diabetes, obesity, hypertension, arteriosclerosis, hyperlipidemia, hypercoagulability, AFib, use of contraceptives, smoking, and cocaine use. And it's important to know these risk factors because if a patient shows signs and symptoms of a stroke with a history of one of these, you do want to alert the provider. So even like if your patient has AFib, if all of a sudden they have arm weakness, facial droop, you want to go ahead and let your doctor know. So these are the assessments, both your physical and diagnostic procedures. So for your physical assessment, manifestations vary based on the area of the brain that is deprived of oxygenated blood. So just kind of keeping that in mind. This is why I kind of told you guys to know the different lobes of your brain and know where things are located, because it makes it easier when you're trying to figure out manifestations. So some of the things we use, so these are some of our common physical assessment tests. The first one is the NIH stroke scale, which is the National Institutes of Health stroke scale. It's a tool used by healthcare providers to objectively quantify the impairment caused by a stroke. It's composed of 11 items with a maximum score of 42 and a score of 0 equals no stroke. So Momentum does have an NIH for reference, as well as a video that kind of goes through it. So if you're wanting to see it, my suggestion would be to watch those. With it, the NIH scale, and I'll pull it up when we're in class, it just shows all these different things that you have to do. It's like a neuro assessment, knowing everything that's going on. The other one is the Cincinnati Pre-Hospital Stroke Scale. This does things like speech, facial droop, and motor response. Then you've got the Miami Emergency Neuro Deficit, or a MEND exam, and that incorporates the components of both the Cincinnati and NIH stroke scale. It's used pre-hospital or if a stroke is suspected, and it checks for probability and severity of a stroke. It tests mental status, cranial nerves, and limbs. So honestly, the two we would use in practice for the facility I worked were both the NIH scale and MENDS. We would do an NIH scale once a shift, and a MEND would pretty much be done every time we did our neuro checks. I like this little card here because it kind of gives you a MEND exam and what you're looking for. Any of the things in green are your Cincinnati scale. So like for mental status, you do the level of consciousness. Speech, you can't teach an old dog new tricks. Questions, age and month, commands, close and open your eyes. So you're trying to see very quickly if they can follow these things. Cranial nerves, you're looking for facial droop, show teeth, or smile. Visual fields, the 4 quadrants. So that's where they do the fingers going up, seeing if they can see it. Horizontal gaze, side to side. Limbs, motor arm drift, close eyes, hold out arms. Leg drift, open eyes, lift each leg separately. Sensory, arm and leg, close eyes and touch and pinch. Coordination, arm and leg, finger, toes, heel to shin. So it's a very quick exam to see whether or not people are symmetrical in their movements. One of the things you do want to teach your general public, and something that all of us should know, is the Be Fast acronym. So they added balance and eyes. I know your book just goes with fast, but balance and eyes are also important when teaching them about this. So the first one is balance. And the reason I say balance is a cerebellum stroke. The patient's only symptom is going to be that balance. So that's why they added it. With it, is the person losing his or her coordination or balance? Is he or she having trouble walking? The next one is the eyes. Is the person having trouble seeing out of one or both eyes? Face. Ask the person to smile. Does one side of the face droop? Arms. Ask the patient to raise both arms. Does one arm drift? Speech. Ask the person to repeat a sentence. Are the words slurred? Is he or she having trouble getting words out? Time. If the person shows any of these symptoms, time is important. Call 911 and get to the hospital fast. Brain cells are dying. So it's one of those things where you want to make sure you know, like if symptoms started 2 hours ago, I want to make sure I know that they started 2 hours ago. And I want to make sure that I let the physician know and let whoever I'm talking to know. So these are the more specific type of manifestations. So it becomes very helpful when it's post a stroke and we're trying to deal with patient care. Because if somebody has a left cerebral hemisphere, these are the physical assessments you will see. So left, the way I remember left is for language. It's responsible for your language, mathematics skills, and analytic thinking. So manifestations include expressive and receptive aphasia, so inability to speak and understand language, agnosia, unable to recognize familiar objects, alexia, reading difficulty, agraphia, writing difficulty, right extremity, hemiplegia, paralysis, or hemiparesis, so weakness, slow, cautious behavior, depression, anger, and quick to become frustrated, visual changes, hypnopsia, loss of visual field in one or both eyes. So if we're thinking about this, what I want you to keep in mind is for a patient that has these disorders, immediately upon looking at these manifestations, what are you going to want to do with them? And something that I would think about is things, and you can put it on pause if you want to kind of think the answer on your own. But some of these things are, if they're having difficulty with their reading and understanding, I'm going to want to make sure that they are talking to speech therapy. I want to make sure that we have some sort of language understanding with them. The other thing I wanted to show on here are the speech centers, because honestly, it makes sense why if I have a left hemisphere stroke, I'm going to have these speech problems. Because most individuals with damage to the left hemisphere develop aphasia, a disorder that makes it difficult to speak or understand language. So you've got the Broca area and the wrinkle area. So the Broca area is the region that controls speech. Dysfunction of this area causes expressive aphasia. Cannot make words, but understands what others are saying. So that means that they cannot actually talk, but they understand everything we're telling them. Wrinkles area is region that allows for language comprehension. Dysfunction of this area causes receptive aphasia, cannot understand words, and can speak but uses illogical language. So this first person is someone who understands what you're saying, they just can't speak it outwards. This person has no idea what you're saying. It's like you're speaking a foreign language to them, but they will speak something that's illogical. This video here, I've got it on Momentum, but it's helpful to watch this video. This patient's been working with speech therapy, and you can see an example of this wrinkles aphasia. So the right hemisphere, this is responsible for our visual and spatial awareness and perception. Our manifestations include altered perceptions of deficits, so overstimulation of abilities, unilateral neglect syndrome, so ignore left side of the body, they cannot see, feel, or move affected area, so patient is unaware of its existence. Can occur with left hemispheric strokes, but more common in right. They have loss of depth perception, poor impulse control and judgment, left hemiplegia or hemiparesis, in visual changes, hemopsia. So when you're thinking about care for this patient, what you have to think is what's going to be best for them. We know that they're going to have that left arm weakness, so still making sure that we're taking care of that left arm, making sure that we are supporting it, because they're going to have that neglect syndrome where they're going to completely ignore that left side of their body. So knowing that, you want to kind of educate them to use that side of their body as much as they can, or to at least like be aware of what's happening with that arm. So for your diagnostic test, a non-contrast CT scan. Now with this is really provider specific. So some providers will opt for non-contrast, some of them will want contrast. Either way, you'll get a CT scan that should be performed within 20 minutes or 25 minutes of patient arrival. What we're looking for is to see whether or not there is any blood associated with the stroke. With it, your priority interventions, this is one of your priority interventions because it's the first thing that you want to do prior to all other stroke related interventions. Because think about it, you want to make sure that you know what you're looking at. Because if I were to give my patient TPA who has a hemorrhagic stroke, what did I just do to my patient? I killed my patient. So you just want to be aware of this. MRIs are used to identify edema, ischemia, and necrosis. It's typically done within 24 hours. A lumbar puncture can assess for presence of blood in the cerebrospinal fluid. Positive finding is consistent with cerebral hemorrhage or ruptured aneurysm. Glasgow Coma Scale, we're looking for that decreased level of consciousness or orientation. So these are some of our interventions. The first thing we have is our medications. So these are all so the first three are all for our ischemic strokes. So with it, you can give TPA within 4.5 hours of the initial manifestations for patients experiencing ischemic stroke as evidenced by CT scan results. Your main goal is to watch for bleeding, because with it, whenever we had a patient that had received TPA, we basically put them on ultimate bed rest. They weren't allowed to get up, they weren't allowed to do anything, because we were very concerned, because we basically, when you give them a true thrombolytic, you're basically destroying all their ability to clot. So these are the kinds of patients that you want to be careful with, because what you don't want to happen is for them to fall and my ischemic stroke is now a hemorrhagic stroke. Anticoagulants, once again, not to be used for hemorrhagic stroke. You can do warfarin, which is given to patients with AFib with a target INR of 2 to 3. You can give them Apaxaban, all these other kind of ones that are just alternatives to warfarin. Antiplatelets, you can give them that low dose aspirin, which is usually given 24 to 48 hours following an ischemic stroke, and it helps prevent blood clot formation. And once again, we're giving them that phenotone for our anti-epileptic medications. So these are some of our therapeutic procedures. The first one is a mechanical thrombectomy, which restores cerebral blood flow. So basically what happens with a thrombectomy, all right, so I have this picture here because basically what happens is with this thrombectomy, it goes up and they can put stents in, or they can kind of remove the actual thrombus through here. You see how they've got this needle here where they've got the mechanical thrombectomy, blood clot is broken into small pieces and removed. So they literally just kind of clean out the vessels in order to restore blood flow. So what they have found is they can do it to up to 24 hours. So that's why even if it's been like 6 hours and they're outside the window of TPA, we still have this ability to do a thrombectomy for an ischemic stroke. It is counter-indicated for treatment of hemorrhagic strokes just due to that anticoagulant therapy. You can do a carotid artery angioplasty with stenting. Stent is placed in the carotid to help open up blockage. And you can do a carotid endarterectomy, which removes our arteriosclerotic plaque in the carotid artery. So that's why we want to know if it's the carotid arteries that are filled with plaque, so that way we can consult cardiology and they can hopefully clear that out. So our nursing here. So you want to monitor the patient's temperature. Remember, a fever can increase intracranial pressure. We talked about that last lecture where we kind of discussed how the hypothalamus controls our temperature. So if there's something pressing on it, it can cause us to be hyperthermia. Cardiac monitoring, your neuro assessments, making sure that you're watching out for changes in any sort of neuro, like your GCS or anything like that. monitoring your vital signs, monitoring for hyperglycemia, which is associated with poor neurological outcomes, elevating your head of bed approximately 30 degrees to reduce ICP and to promote venous drainage. So yes, this hyperglycemia, just because that high sugar can cause damage to the vessels. So that's why it's associated with poor neurological outcomes. But like I was saying, in order to decrease your ICP and promote venous drainage, what you want to do is have that head of bed up 30 degrees and maintain head midline in that neutral position, especially with your hemorrhagic strokes. You want to initiate your seizure precaution and initiate bowel training. So you want them, this bowel training, the way it works is you want them to go to the bathroom at the same time every day. So the reason for that is because it trains the bowel that, okay, at 3 p.m. is when I'm going to go. So it has nothing to do with when they eat. It all has to do with how did I schedule this out with my patient. If I said that we're always going to go at 2, that's when I need to do it. The other thing is our communication. You want to assist patients with communication skills if speech is impaired. Remember that our left hemisphere strokes can cause those speech problems. So you want to assess the ability to understand speech by asking the patient to follow simple commands, observe for consistently affirmative answers when the patient actually does not comprehend what is being said, assess accuracy of yes and no responses, supply the patient with a picture board of commonly requested items/needs. For expressive and receptive aphasia, speak slowly and clearly, use one-step commands. So for your communication with a stroke patient, you really do have to kind of lay it out very simple at the beginning of, do you want me to turn off your light? Yes or no? Do you need to use the bathroom? Yes or no? It's kind of keeping it, because it's like that cognitive thing where we want them to understand what we're saying, and eventually you can kind of understand what they mean by certain language. The other thing is our feeding. So you want to assess your swallow and gag reflexes, watching for aspiration. There's 4 different liquid consistencies. You've got thin, nectar-like, honey-like, and spoon-thick. So thin is basically just your water and juice. Nectar-like is your creams, your nectars. Honey is basically the thickness of honey and yogurt. Spoon-thick is pudding, cooked cereals. So it can kind of help with knowing how they swallow. Food levels of dysphagia are things like pureed, mechanical altered, advanced, mechanical soft, and regular. And you want the patient to sit in an upright position and swallow with the head and neck flexed slightly forward. And I'll demonstrate it in class, but it's basically like putting your chin to your chest, and it closes the it closes that space for them to actually swallow. So when they swallow, it's less resistance for it. And you do want to collaborate with both dietitians as well as with your speech therapist. And this video I'll show it in class, but it's just a modified barium swallow video. I always like showing it because with these modified barium swallow videos, they show where the food is actually getting stuck, because there's like a little pocket where the food gets stuck, and that's where they get concerned. And it's kind of helpful to realize, okay, that's why they need a thicker fluid, or that's why they need a modified diet. So that way it actually goes where it needs to go. Some of the other nursing care are things like watching for complications with immobility. So things like atelectasis, pressure injuries, DVTs, everything of that nature. If the patient has one-sided neglect, teach them to protect and care for the affected extremity to avoid injury. So things like they might hit it with a wheelchair, doorway. So making sure that they're aware of, you've got that left-sided neglect, you need to support that arm. So with our right-sided cerebrovascular accidents, if you remember, they usually have that neglect of their left side. So if you've got that right-sided cerebrovascular accident, you just want to make sure that they're supporting that left arm and that they're avoiding contractures. So you can be things like supporting them on a pillow, using hand roll, which is a type of technique that can kind of help them with their exercising, that can help prevent those contractures. And the reason I bring up the right-sided cerebral vascular accident is because they're the ones that typically have that neglect. Now, with neuro cases, every neuro patient can be a little bit different, but these are like the most common things that you will see. You want to maintain a safe environment to reduce the risk of falls. So encouraging the use of assisted devices, transfer belts, adaptive devices, sliding boards. So a way that you can see if a patient is adequately functioning is if they're using these adaptive equipment appropriately. And remember, you got to be kind of careful because some of these stroke patients can be very impulsive, and it's just all about getting that right education and getting them to the point where they know, family knows that they need to use those adaptive devices. And a lot of those are usually trained through occupational therapy. Assist with ADLs as needed, instruct patient to address the affected side first and sit in a supportive chair and then do the unaffected side. Patient will have decreased endurance, so kind of making sure that we're not overstimulating them. Support the affected arm to avoid dislocation. And like I said, that becomes very important with our right hemisphere strokes, because remember, a lot of times that right hemisphere stroke, they've got left neglect. So you just want to make sure that they're supporting that left arm. They can do hand exercises to avoid contractures, and you want to support patient during periods of emotional lability and depression. These are just some of the hand exercises that they can do. A lot of times occupational therapy will just kind of train them how to do these things. The other one is the hominis hemiopsia, which if they have that, that means that they have loss of the same visual field in both eyes. So that basically means that in both eyes, they've lost the same amount. So this one works a little bit differently than some of our other instructions. That's why I put it on here. So for them, you want to instruct them to use a scanning technique. So turning the head from the direction of the unaffected side to the affected side when eating and ambulating. So for them, you just want to remind them to turn the body to scan to that lost visual field. So they would have to turn their whole body so they can actually see it, which is different than when we are working with our patients who have neglect. Finally, just talking to speech and language consults, physical therapy, occupational therapy, and social services. All of these work together to kind of manage our patients' care. And that's everything. Let me all know if you have any questions. Thank you.